If this were a drug, it would be a billion-dollar drug out of the gates. Hopefully this doesn't offend the academic purists, but you have to break some rules.
I know exercise is good for you, but is it really going to make that much of a difference?
Exercise in cancer really has had the better part of 40 years of solid evidence supporting it.
A patient choosing to enter into one of your prehabilitation programs, what would they expect?
What are the best trials doing? What are the most innovative groups doing? I'm a real proponent of making sure that there's a clinician somewhere in the loop of care, but...
Hello, welcome to the show. Today I'm going to be sitting down with Dr. Daniel Santa Mina, Professor of Exercise and Cancer at the University of Toronto. Over the last 15 years, Daniel has authored over 130 publications with a focus on understanding how exercise improves outcomes for cancer patients. Apart from his impressive academic background, he is also the co-founder and CEO of PrehabRx, an organization dedicated to bringing the impressive effects of exercise pre-cancer treatment to cancer patients everywhere. And the research is very strong. An article published just earlier this year in the New England Journal of Medicine showed how structured exercise programs can improve the quality of life and survival rates of patients who have undergone surgery and chemotherapy for colon cancer. I wanted to sit down with Daniel to get a better understanding of how prehab as a concept works for patients and how it can be used to improve patient outcomes. In this conversation, we also talked about balancing both being an academic and an entrepreneur, and most importantly, how the Canadian healthcare system has made it challenging for implementing these innovations, but why there's reason for optimism in bringing this innovation to scale. If you would like to reach out to Daniel and learn more, you can email him at daniel@prehabrx.ca. And now, let's get to the conversation. Hello, Daniel.
Hello, Noah.
It's wonderful to have you here today.
Thank you for having me.
So we are sitting down with Dr. Daniel Santa Mina. Welcome to the office, and looking forward to our chat today.
Yeah, me too, Noah.
I guess, if you don't mind, can you give a little bit of background on yourself? A little bit about your professional journey and what has led your career to where you are right now?
Sure. Where to start? Well, fitness and health have always meant a lot to me. And I think from an early on, I thought that my career would have some element of fitness and health as a part of it. I really wasn't sure what it would look like, but I think I always knew that that was an important element of what I wanted to do. I always enjoyed sports. Kinesiology made a lot of sense for me as an undergraduate pursuit. And then from there, really just started to grow my appreciation for health and fitness and how it could be applied to more than just sport, but rather to chronic disease and mental health and a whole host of other areas of life. And so following my undergrad, carried on into graduate work, eventually where I focused in exercise oncology, subspecialized in a space called prehabilitation, and over many number of years, tried to explore what I thought were important areas of the field, whether it was related to the mechanisms of the benefits of exercise for people with cancer, how getting fit for surgery improves surgical outcomes, and how we could take what seems like a simple intervention and put it into the lives of more people who typically weren't. And so I ended up doing a postdoctoral fellowship in the Department of Surgical Oncology at the Princess Margaret Cancer Centre. And there actually is when I started to really try to explore two things. One is, can we create an exercise and rehabilitation program that was something integrated into the care journey for people with cancer at a large cancer institute like the Princess Margaret? And B, could we actually start the journey a little bit earlier? Could we prehabilitate them in ways that would lead them into surgery in a better state so that they would come out of the operating room quite healthy? And so immediately following my PhD, in fact, I started a postdoctoral fellowship that was concurrent with a role that I had leading the kinesiology program at the University of Guelph-Humber. And after a number of years as the program head there, I felt like returning back to a more traditional academic role at the University of Toronto made a lot of sense for the work that I was doing. It was, within close proximity of my lab at the Toronto General and the Princess Margaret. And so I started a tenure track at the University of Toronto and just kind of worked my through the career path from, I guess that's 2015 or 16. Okay. And so I've been at University of Toronto ever since and University Health Network, building a number of different programs in exercise and rehabilitation.
And now I do want to kind of
drill down and focus on the concept of prehab and how that fits into oncology and the evidence behind that and what you specifically do. But before we do that, there was an aspect of the approach that you're taking to providing access to this kind of research and evidence and clinical programs that is a little bit outside of the scope of academia, and that's also in the commercial space. And so you have experience stepping out of academia a little bit.
Right.
And so do you mind talking about that for just a second?
Sure.
Because I know from the point of view of academia, the corporate world is this gray, forbidden zone in some ways.
Yeah.
But it doesn't have to be, and once you're in it, it's kind of different. So if you don't mind talking about that, and then we're going to loop it all back together to see how that connects to the work you're actually doing now.
Yeah, I think forbidden zone is a term that probably doesn't make a bit of sense for it. And it's also a black hole, because I think from an academic career space, you don't know what the rest of the world is like. You're so focused in a particular area and building an understanding of a given subject matter, how to execute research in a very specific space in a very specific way, and you become very expert in a very narrow area of space. That can be very important, but you can lose sight of how other things operate. From a personal professional standpoint, having been in the university system for almost 2 decades, I think I needed to see what life was like on the outside. I needed to see whether or not I could translate some of my skills to a new environment, and figure out whether or not I could change health in a new space with the tools that I had developed in an academic training and career. And then the other professional component was I had been, quite excited, and still am excited by the work that we do at the hospital and developing programs for people who haven't necessarily had as much access to them. But at the end of the day, we end up serving, again, just those who are patients of a given institution. In the corporate health space, there's an opportunity sometimes to actually try to scale what you're looking at trying to build to a national level. And rather than serve 100 people or 1,000 people, you're looking at trying to service millions of Canadians. And so there was a real exciting opportunity to figure out whether or not we could take health products that we knew worked in a lab and move them into spaces and extend them beyond the borders of our usual community. And so I spent 2 years in a corporate setting in a large organization, and I learned a ton. But there are a number of great things going on at the university and really cool opportunities at the hospital that I was missing. And it was great to get back to it, but very appreciative for the time I had in a corporate setting.
Very cool. And so, reflecting on that, I went corporate right after my postdoc. For that very reason, the idea of in the academic environment being, doing interventions, jumping from grant to grant, doing a specific intervention at a specific organization, specific amount of time, but then the translation of that to helping to bring that knowledge to more people, actually a faster path is in corporate.
Yep.
And so now, just reflecting on my own past 10 years or so, we've done programs for mental health, diabetes, cardiovascular disease, chronic pain across different organizations, across different geographies.
Yep.
And so it is an interesting balance between what the focus that you have to have in academia versus the scale that you can get in corporate.
And sitting from my side of the table and watching your career flourish on the corporate side, I'm equally envious of what you've been able to do, describing all the things that you were doing and having impact at scale while we were working in somewhat smaller environments, not at the national level, but typically at a local level. Although we've had a number of national trials, trials have boundaries on them. They have financial boundaries that limit you to X number of years, the funding ends, or they limit you to certain population groups with exclusion criteria that leave out people who are in high needs. Whereas in the corporate setting, it's so much more agile and flexible and allows you to really try to fit the product or the service into the communities that you're trying to operate. I think that there are equal opportunities for both sides to create a lot of impact. They just do them in different ways. The academic space creates understanding of how something works and why it works that a commercial or corporate space can then exploit and then distribute it at mass. But the corporate space is never necessarily going to take the time it takes to drill down on the questions, to unearth those nuances that have created the impact from the beginning. So I think they really are complementary to each other. And I'd agree, like there is a sentiment where you're joining the dark side if you go commercial or you go industry. And then there's a sentiment in the industry space where, you know, if you're in the academic world, you are either out of touch or you're moving at snail's pace.
Right. And I know that a lot of your work now is starting to include technology.
Right.
And one of the areas that I find has a lot of challenge in the academic world is the idea of when you're creating a clinical trial, you may need to maintain consistency across the entire duration of that clinical trial. But the speed at which technology changes, like I remember when we were doing our first clinical trial with diabetes using version 1 of our platform, by the time the trial was done, that platform was outdated and obsolete, and there was a new platform to take its place. So the publication reflecting on that clinical trial, the next clinical trial, the next delivery of the intervention is going to be on a different platform.
Right.
So does that research and publication have validity even though the platform is different? It raises these questions. And now with AI, it's like the pace at how the technology is innovating is so fast.
Yeah.
So very fast.
Yeah, I think, you know, academic purists will say that if you test something and it works, then you need to use that exact thing in the real world to generate the same outcome. But like you just described, over the course of a trial, the technology can change in such a way where that thing that you tested is no longer available when you want to implement it at the real world level. And I think, frankly, as much of, hopefully this doesn't offend the academic purists, but you have to break some rules. Right. The technology is just simply not the same. But I think when the fundamental principles are the same, when the goals of care, the goals of the product or service are the same, and technological enhancements have been made, features have been added, slightly adjusted, I think that we need to appreciate that there can be a bit of wiggle room here. And that, you know, your version 3.0 doesn't necessarily mean that you have to test it the same way before you use it because 2.0 was used in the last trial. We're with 3.0 now. Things have improved. We learned those things. We shouldn't ditch them on another trial because we will do that forever. We will never get to a place where we take the technology of the now and put it in place for the people who we need to serve today. We'll always be using older technology.
Right.
So you need to break a few rules if you're going to move data in or technology into care today, because what was tested is not going to be the same as what's available.
And actually that leads us really smoothly into this next kind of like focus, which is really about that transition between research and knowledge and understanding. You know, exercise is good for you. There's been a few clinical trials that have shown that.
A couple.
So the transition between taking that knowledge and that evidence and then actually making change in the healthcare system.
Right.
And in your specific case and your expertise in oncology. So what does that landscape look like? How is the academic, clinical, medical side in oncology treatment and support starting to adapt exercise and prehab and rehabilitation?
Yeah, there's such a history to this specific area that we could talk for several hours about exercise oncology. But some of the initial literature that supported the feasibility and just the safety of exercise for people with cancer came out in the 1980s. We are, 40 plus years of data supporting exercise's feasibility, safety, and benefits for people with cancer. And I think that in this particular space, it simply has taken as long as it had because the risks are high. these people can be quite ill. They can have a number of scenarios for which health can turn quickly, and we need to care for them in a very sensitive way. And I think what we've learned over thousands of trials at this stage is that we can do it. We can actually deliver exercise to people who are quite ill, going through a lot, in ways that are adapted to their capacity and ones that allow them to benefit as other people do with exercise. They become stronger and healthier. They think more clearly. Their quality of life improves. Their fatigue goes down. And it tempers or manages or can sometimes reverse some of the challenges that treatment, which can be very toxic. It improves so many of the treatment-related issues. So exercise in cancer really has had, the better part of 40 years of solid evidence supporting it. Now, while researchers in this particular space have known this well, it has taken some time for the clinicians who see these patients all the time to start understanding that the evidence is of high quality, that exercise can be adapted appropriately. It could be applied in a number of settings. It's not necessarily just with a healthy cancer patient, but rather sometimes with patients who are really struggling with a lot of symptoms of the disease or the treatment. There were some challenges, maybe I'll use that word very specifically, about the data, although the mass of data was just so overwhelming that in general it was appreciated that exercise provides benefits and such that the recommendations for exercise are widely there are wide recommendations for exercise in the course of cancer care. But in the past 2 months, I'd say we really have had a resurgence of the importance of exercise.
The last 2 months.
The last 2 months.
Okay.
Like we are at this, if we didn't hit a tipping point earlier, which many of us in the field probably thought we'd hit a long time ago, a recent publication in the New England Journal of Medicine of the challenge trial, which looked at almost 1,000 adjuvant colon cancer patients and a structured exercise program, produced a 7% survival benefit versus those in the control group. And for perspective, 7% survival benefit, if this were a drug, it would be a $1 billion drug out of the gates. But it's exercise. It's not simple, but it's doable, and there are ways to do this for many patients. So I think the level of evidence that has just emerged, published in such a prestigious journal, and done so meticulously by the investigators, has created a scenario where it's undeniable. The exercise benefits are there for the most critical outcome, survival.
I'm curious, if you were to make a recommendation to a person who had just been diagnosed with a form of cancer. Let's take away the, how shall I say, the academic speak, and like, how would you actually just speak to an individual that just got diagnosed with cancer, maybe in various stages, maybe pre-treatment, during treatment, post-treatment? What would be your recommendations to somebody?
Let's help you move more. Let's understand where you are now in terms of your physical function. Let's see how fit you are, and let's see if we can try to keep you that fit or improve your fitness. And we will do whatever exercises you enjoy, that are safe, and that we think try to help you get a little closer to your goals of feeling better. Sometimes people stand up out of a chair, and that's a challenge for them. And then other patients are doing high intensity interval training. And we've done studies that have ran the gamut from very, very low intensity to very, very high intensity. And at the end of the day, everyone's exercise prescription is their own. And so I don't think anyone needs to have a vision of exercise that is predestined based on what they've seen on TV or what they used to do when they were 20. We are who we are when we are that person, and we have to exercise within kind of the parameters that our body allows. And for people with cancer, there are so many variables that we have to adapt for. But that's not really what we want the patient to think of. Really, when I'm talking to a patient or when our teams talk to patients, it's really more about how can we help you move more? How can we, if we can do that, the fitness will take care of itself. And we just try to simplify it as much as we can.
And really, it ends up being like, let's get you to move more, but to really hit home how much it's going to benefit. And that gap between like, okay, I know exercise is good for me, but is it really going to make that much of a difference? Like, I guess hitting home on that point on, no, this is makes a significant difference in your experience going through this cancer journey. Is that right?
I'll take an example of probably the most pervasive and among the most problematic symptoms that people face undergoing cancer treatment, which is fatigue. It is a type of fatigue that is unrelenting. It is not precipitated by another type of activity necessarily. It is just this constant weight of tiredness that people with cancer often describe. And it's very hard to kind of break that feeling of just exhaustion all the time. It's not that they didn't get a good night's sleep. It's not that they, had a hard day at work. It's just they're routinely and consistently tired. But what the evidence shows is that exercise is probably the best treatment for cancer-related fatigue. And when we talk to patients about fatigue, there's a bit of a discomfort of exercising to reduce fatigue because the general thought is, well, when I exercise afterwards, I'm tired. I mean, sometimes some analogies, help. And one analogy that you and I have talked about in the past is this idea of, what it's like to, carry a weighted backpack around all day. You feel suppressed, you feel weighted down, and it just makes everything you do much more difficult. But when you exercise, to some extent, what you're doing is you're building your capacity to carry that weight more. And as you build up strength and as you build up endurance, that weighted backpack doesn't necessarily feel as heavy because you're able to manage it better with, additional fitness. And so ideally what we try to do is help people exercise despite their fatigue to allow them to have the physical strength and fitness to manage that fatigue and break the cycle of them becoming more deconditioned, becoming more exhausted when they do shorter bouts of activities that usually wouldn't make them fatigued, but because they become so deconditioned, make them even more fatigued. So if you're not exercising, you have this cycle of fatigue, I do less, get less, I become less fit, and then therefore anything I do makes me more fatigued. So I do less, and then I become even more unfit, and then you just cycle all the way down into a space where you really have very little energy to do anything. And what exercise does is it breaks the cycle. It tries to maintain a degree of fitness that allows you to maintain your activities and manage that weight or that burden of fatigue better so that it doesn't kind of put you in this perpetual spiral of poor fitness, less activity, less fitness, less activity, less fitness.
Right. And so in that, so if a person has cancer and they're sold, they want to start exercising, there are specific professionals that you would recommend to work with? Like there must be exercise-specific kinesiologists or personal trainers that would make sense to go with?
There are a number of great training programs available to help improve a health professional's knowledge about how to prescribe exercise for someone with cancer. One that comes to mind is Thrive, out of some colleagues from the University of Calgary. Professor Nicole Koulos-Reed and Dr. Lauren Capozzi put together a fantastic curriculum for exercise professionals to understand the considerations that an exercise professional would have to make to care for a person with cancer. I think that kinesiologists, clinical exercise physiologists, physiotherapists, they're probably the health professionals that tend to be the ones who provide exercise programming for patients. And they're well qualified, as generalists very often, but exercise is a beast unto itself. So there are training opportunities in oncology specific for exercise professionals, and I generally recommend that if someone is looking to exercise and they have been diagnosed with cancer, that there probably are some professionals out there who can help manage them without a specific credential, but the specific credentials in oncology kind of provide a level of maybe comfort or credibility in terms of knowing that they will be able to anticipate or understand the challenges that a person with cancer are going through.
Right. Like, and even while somebody's going through example, like chemotherapy,
Right.
there are days where they have energy and can do things, and days not so much. And so that kind of understanding.
And it varies from hour to hour,
Right.
day to day, week to week, depending on the cycle, the timing. It is, when training somebody with cancer, the session starts almost like a blank slate. How are you feeling today? That's where every session starts. But just because someone is feeling good at the beginning of the session doesn't necessarily mean that they don't rapidly fatigue in an unanticipated way, and something has to be adapted mid-session. So we generally err on the side of maybe more supervision than less with people with cancer, especially when undergoing difficult treatments or if they have a number of adverse effects that they're managing. But these treatments are so tough. So we're pretty sensitive to the variability in the ability for a patient to do something from, like I said, basically hour to hour.
Okay. And now, knowing all of this evidence exists on the importance, the efficacy, how the outcomes of the cancer treatment can be positively kind of shifted with exercise. What are the barriers to scaling these kind of exercise-related oncology programs in the system, in the medical system? Like, is it assumed that if you get a diagnosis of cancer and going through treatment, you're going to automatically get referred to an exercise specialist, or no?
Another great question that hundreds of papers have explored and tried to describe, and probably is up there with one of the more important questions to be answered by research, or at least be discussed by stakeholders. At the Princess Margaret, we are very fortunate to have a very robust cancer rehab and exercise program. And for patients at the Princess Margaret Cancer Centre in Toronto, there probably is an expectation that their health and well-being beyond controlling the tumor will be managed in a very comprehensive way, which could include exercise. I'm not necessarily so sure that most patients would expect to have exercise as a part of their care, but the clinicians now are very familiar with this program and will refer routinely. And it's really a part of the experience for people with cancer at the Princess Margaret. But beyond a few centers in Canada and around the world, a lot of people really don't have access to this type of care. They've either not heard the research, or there's no program near them, or there's no health professional who's qualified to manage this. And that issue stems from a lack of resource, usually, for these services. I don't think there's a debate anymore about whether or not exercise is good for a patient. The challenge is really operationalizing it in a way where there are so many resource constraints, for which when you have only a finite number of dollars and you are short on operating room nurses or other health professionals, where are you going to put your money? And frankly, the healthcare system has a lot of needs. Exercise is one of many, many needs. And so unless you're in a large tertiary care center, the resource allocation to something like this probably gets deprioritized. And so probably a lot of patients aren't getting exposed to it because there really isn't a program available to many of them.
And so part of what you're doing now, and a differentiation which I think it's becoming more popular in academic circles, but most lay people will know what rehabilitation is.
Right.
Rehab.
Right.
You go in an oncology context, you get a diagnosis, you go through treatment. Rehabilitation is on the other end of that.
Right.
But your specialty is actually focusing on prehab.
Right.
And so can you dive in a little bit about that? So what is prehab and why? Why is prehab?
Yeah, why is prehab? Well, like you said, rehab is well known. You're injured, you know that the body needs some time to recover. There are some exercises or some things you can do to help your body recover in a way that allow you to put that injury in the rear view mirror, so to speak. Prehab is a concept that, quite a long time ago, I just became curious about because, we would never go into, like we started off at the beginning of our story talking about my interest in sports and my interest in applying exercise to health outcomes. We would never go into a very challenging situation unprepared. We would never run a marathon. We would never play, a basketball game of high, of high importance without being ready for it. Because the more ready you are for a challenging event, generally speaking, the better you are, the better the outcome is. And I think there had been a growing body of literature that basically described healthier patients that went into the operating room generally had better outcomes than those who were unhealthy. And so that's fairly intuitive. But the question then was, could you take someone who was unhealthy and make them healthy in this period of time prior to surgery, which isn't always a long time. Sometimes it's only a few weeks. So the idea of prehabilitation is really about taking someone of a given health state and getting them as prepared or as healthy and fit as they can be before they go into this major stressor that is typically surgery, so that their surgical outcomes are better. And in many ways, it is like training for a marathon. And it's not necessarily just exercise. I mean, we think about these events as physiologically demanding and such. We want to make sure that we can, from a fitness standpoint, bear the challenge that's imminent. But if you were to run a marathon, you would have to be mentally prepared. What is your 10th kilometer going to feel like? What is your 20th kilometer feel like? What is your 39th kilometer going to feel like? And how are you going to get over those last few to ensure that you finish the line? Because 39 kilometers is not the end of the marathon. So mentally, can you be ready for these different stages and how will you likely feel? But it's not necessarily just how fit you are or how resilient you are mentally. Do you have the fuel you need? And just like in a marathon, you need to necessarily be prepared from a nutrient standpoint. So when we think about prehabilitation, we often consider it something that you need to use a multimodal approach for. And the three general pillars are exercise, nutrition, and psychology, but there are a lot of other really cool areas that are being explored to help optimize health in this preoperative space. My recent PhD graduate, Dr. Daniel Sibley, was doing his research in sleep optimization prior to surgery. And can that help create an even healthier person if sleep were a challenge? And other folks are looking at different spaces, more medically, and other areas of health behaviors. So the idea is really just being as prepared as you can be. And generally what we've been finding in the research that we've done, as well as other colleagues in the field, are anything from reduced number of days in hospital, fewer surgical complications, a better recovery trajectory, improved functional capacity pre and post-operatively. The evidence in this space is probably about a decade behind the exercise oncology in the rehab space. But there are still hundreds of trials that have all leaned towards you're in better shape after surgery if you've prehabilitated. Mm-hmm. We would benefit from that, grade A quality RCT data in prehab. So I think that's a high priority for that particular space. But the data widely skewed towards benefit versus none.
It's such a great way of framing it. Like, you wouldn't just jump into, as you say, a marathon with your fingers crossed and hope for the best.
Right.
Like the idea of preparing yourself physically and mentally for it, from a common sense point of view, it makes sense. And not necessarily from the point of view of like, you want to train so you can get a good time. You want to train so you can get through it.
Right.
And so if you just perceive the experience of treatment for cancer which sucks.
Yeah.
Like there's no sugarcoating.
No.
It sucks.
Terrible.
Preparing yourself for it. That's great. And I think that message will resonate with a lot of people. And
yeah, I hope so. And I think it has. You know, at the Toronto General Hospital, my colleague, Dr. Ian Randall, and I have had great support from the senior administration to build out a surgical prehabilitation program. And we have nearly 1,000 referrals every year for all types of surgeries, whether in oncology or cardiac surgery, solid organ transplant, orthopedics.
hip and knee, I'm sure is huge.
We see basically every type of surgical patient within our program, and they all come with different needs and different challenges, different surgical timelines. In the oncology space, they're often undergoing other treatments before surgery, like neoadjuvant chemotherapy or radiation therapy, that are reducing a patient's fitness actively prior to surgery and putting them at a higher risk.
Right.
So we try to maintain their health and fitness throughout some of these other challenging neoadjuvant therapies so that they can go into the operating room as healthy as they can be.
Okay. And so, you know, a patient choosing to enter into one of your prehabilitation programs, what would they expect? What is the interaction with their exercise specialists? What is their commitment to going to the gym, or is this a remote thing? Like, how do you deliver the program, and what would a patient expect to experience?
At the Toronto General and the University Health Network Surgical Prehabilitation Program, what we've tried to do is mirror what we've seen to be where the evidence suggests the most benefit. And again, we try to follow a multimodal approach. Once a patient is referred to us, we do a baseline assessment to understand how fit they are, what their needs are, understand the treatments that they are currently receiving and those that they may receive down the line.
So baseline assessment being?
Physical fitness assessment. Sometimes it includes a cardiopulmonary exercise test or your VO2 test, or sometimes it's a 6-minute walk test. And then we have frail patients for which both of those tests are difficult, and we might do a sit-to-stand test or one of the other validated measures of functional capacity. And ultimately what we're trying to do is get a sense of how fit is this patient and what would the right exercise prescription be for them, so that we don't necessarily shoot that exercise prescription and put them into a space where it could be uncomfortable or dangerous or something they just want to be able to do, but also make it sufficiently challenging for them so that we can push them to a place of better fitness and help them adapt over the few weeks that they have before surgery. So once we've seen them at a baseline assessment, during that baseline assessment, we're also asking them questions about their nutrition. We're asking them questions about their readiness for surgery mentally, and we're trying to see whether or not integrating elements of nutrition and psychology, for which we have team members who specialize in that in the preoperative space, can help support care. And so from the time of the baseline assessment to surgery, they typically will receive, some number of consultations with a kinesiologist to manage their exercise, and then they'll probably meet once or twice with a dietitian or psychologist to help them manage their psychological preparation for surgery, as well as stress management and health behavior change. And from a nutrition standpoint, make sure that we minimize the risk of being malnourished while optimizing other nutrition needs.
So those consults with a kinesiologist, for example, are they exercising in person together, and they're acting as a trainer, or is it more to review what they're doing at home, what the patient is doing at home?
Okay, so the exercise prescription is based on the baseline assessment, and that's going to be tailored to the person's preferences and functional capacity. And then the kinesiologist will meet with them in a cadence that aligns to the patient's needs. Some patients just need a little bit more hand-holding until they become independent. Others are pretty self-sufficient once you tell them what to do. So some patients tend to come into the hospital routinely, or maybe they just need a virtual consult once a month. We really just try to meet the patients where they're at. If they need a bit of hand-holding to get them into a space where they can exercise routinely and comfortably on their own, then we do that until they're self-sufficient. If we deem that they're pretty comfortable doing this on their own, then we probably follow up with them a little bit less.
Okay. You've also, to scale this outside of that and to make the programming more accessible, you've started a new venture, PrehabRx.
Right.
So what is PrehabRx? Can you talk a little bit about that and how that's kind of changing approaches to access?
Yeah. PrehabRx and this journey into the entrepreneurial space has been very exciting. It's born out of, I think, what we've seen is a huge need outside of our institutional catchment area. At the University Health Network, at UHN, we really do have robust care in many spaces that a lot of other institutions don't, even those who are within a few kilometers of our institution. And so we've done a lot of research in trying to understand how to drive accessibility across the country. We've done research on the barriers and facilitators to care. We've done a lot of research on trying to move exercise outside of the walls of some of these larger institutions where so many Canadians actually receive their oncology care or their surgical care. But yet we still know that unless you're in a major institution, you're unlikely to get exercise, prehab, rehab, whatever it is you need in the course of your journey. And so PrehabRx was born out of this gap in care that we identified, and it's not necessarily something that researchers were, the only ones privy to this issue. I was presenting at a conference a conference in Vancouver on lung cancer, and I was talking about prehabilitation in this particular space, and I met with an enthusiastic physician, Dr. Zia Punja, who's thought, this is really great data. This can change the lives of my patients. How do I get this in Victoria? Mm-hmm. And I would give the same spiel that I would give to all the other people who I would talk to after one of my presentations. Well, the way I did it was we started with a research project. We built onto that research project another research project. And there's just such a long road towards implementation through this research route. And he said, no. You just told me the data were good. You just told me that these are the benefits. We need to have these now for the patient. The patients I'm seeing tomorrow need something like this. How do we do this? And so we thought a little bit about this, and his enthusiasm was infectious. And he said, we got to try something else. And really, I think what we were really focused on was scale and access and being agile to the needs of communities beyond some of these major centers. And I think we saw an opportunity in this commercial space that allowed us to really focus on scale and agility. And so we took this idea of prehab and exercise oncology into an incubator at the University of Toronto, one called H2I, another program called Lab to Market. And these incubators that are connected to academic institutions are really cool because there are so many inventions that are happening in labs all over these universities, and they're coming up with a new material or a new chemical compound or something that could have great application to millions of people. But you need to figure out how to move that thing into the masses and make it accessible in a way that people could benefit from. And that was really what we were experiencing. We were experiencing great benefit from this thing that we were doing in the lab, but there's a massive gap in getting it to market. So we have been working with a University of Toronto incubator, like I said, H2I, a program called Lab to Market, and it really helped us focus on the importance of driving scale, being agile, and figuring out how to put this into the hands of the people who need it. And so PrehabRx is really just an exercise program that helps people prehabilitate prior to surgery or helps them exercise throughout the course of cancer care. So it's an exercise oncology service either on the front end of surgery or on the back end of surgery. It's not necessarily oncology specific, although that tends to be where we deliver care because it's really in our wheelhouse of expertise. And it's been an amazing journey that I've been able to apply what I've learned through academic training and then utilize the new skill sets pulled from my corporate experience and then grow them within this company.
But so how are you solving the problem of accessibility to people outside of out of urban centers? Like how are you scaling it? How are you making it accessible?
How do we make it accessible? The program is free. It's free to patients. I mean, obviously we have to find payers. So that's really the work we do. Is we try to deliver what we know works for patients, which is exercise. That part we know. But what we've been working to figure out is where do we find other stakeholders who find it valuable to have healthy patients. And at some point in time, you have to draw the line between a healthier patient and revenue for businesses to thrive. And so the Lab to Market and the H2I program have really tried to push us to think about who would find value in a healthier patient. And one particular industry for which the data are emerging, supporting a potential value proposition of exercise for patients is pharma. If patients can tolerate the side effects like fatigue better, maybe they won't switch their drug if that particular drug is making them very tired. And if they don't switch their drug, well, then that pharma company will be able to have that patient on that drug for a longer period of time. Or maybe a given drug is reserved for patients of a particular health status. Could we create a larger eligibility pool for a patient with a given cancer because you have patients who typically are unfit, but could we make them fit enough to take the drug, thereby increasing the number of patients who could utilize it and then drive revenue again for a pharma company. Right. These are just two of many examples that we've been pushed to think about other industries or other potential stakeholders funding this for patients to ensure it's free for the patient.
Okay, and so the dollar amount on it from an accessibility point of view is one part of that. Right. I guess I'm also curious about the physical access.
Yes.
So again, does the program require being physically in front of a kinesiologist like we are now, or is this a digital virtual?
It's a digital program. I should have started with that, Noah. Okay. I'm sorry.
It's okay.
It's a digital program.
So I'm here asking the questions.
Yes, you ask the questions and I'll answer something else. The cool thing about what we did when we built PrehabRx was that we had to think about scale, being agile, but we thought blue sky. What could we do? What are the best trials doing? What are the most innovative groups doing? And I love in-person care, so I don't ever want to suggest that there should be a transition to only digital care, because there is something about the human connection when you're in a room and you're working out with someone that means a lot to me, and I think it means a lot to a lot of patients who prefer that. But it's not necessarily a model that allows for everyone to participate comfortably. Some patients don't want to get out of their house, and the only way they're going to exercise is if someone is actually on a screen or comes to their house to tell them what to do. So at the expense of having that in-person interaction in the same space, this is entirely digital. And yes, indeed, we don't have that one-on-one in the same space experience, but we do have the opportunity to deliver it to way more people who would never otherwise have it because their community just didn't have an exercise professional who was qualified in this or comfortable in this space, or they didn't have a setting that was set up well for people with cancer. So the goal really was to try to create a digital service that embodied the best features that we could come up with from others in this area.
So that's awesome. And it's not like you're, and coming back to that conversation of, testing something in the academic environment with clinical trials and then trying to make that available. Doing this digital, this is still an evidence-based approach.
Of course.
There is still a lot of evidence that suggests that you can still deliver amazing results and not physically be in front of somebody, even though I completely agree. It is great to be physically there with you.
Yes. I would say probably about 10 years ago, there'd be a handful of studies that looked at the role of digital interventions for people with cancer. You open up the population of interest, there's probably a good number of studies that have been looking at it. Technology has been moving fast over the last few decades, but the pandemic was a massive turning point where there was only one option for care for most people. And the pandemic opened up the opportunity to solve problems that really weren't in our face the same way. Accessibility into rural Canada was an opportunity to drive care to regions that didn't typically have it, but that is a fairly niche area of research to be in, right? I want to deliver a particular intervention to a particular region of the country that doesn't have access to bricks and mortar types of services. Very, very important, but not mainstream. The pandemic hits, digital care is mainstream for everybody, for every service.
Right.
And so I think a few things happened that kind of led to us going in this direction. A, patients are more comfortable with it. It's not impossible to get a patient into a video call and do an exercise assessment and come up with an exercise plan. During the pandemic, we've had to pivot and we've seen benefits of exercise programs delivered virtually. So it's not like it's washing out the entirety of the effects that patients who are seeing in person were delivered. It wasn't washing out those in-person effects that were being observed in previous literature. The technology advanced rapidly to match the needs of digital care. So exercise prescription became more robust, more video and more comprehensive video libraries, more digital tools. It just became an area that was almost an essential complement to in-person care, but it had to be robust. And so again, to this idea of blue sky thinking for an exercise program for people with chronic disease, what did we need out of it? We needed a ton of health behavior change tools. We needed secure, reliable, strong privacy features. We needed to be able to connect a patient with a clinician who was expert. At least from my perspective, there's still an element of accountability that only a human can provide.
Right.
I love what AI can do, but I'm not necessarily so sure that people are as accountable to AI as they are to another person who's waiting on the other end for their session to start. So I'm a real proponent of making sure that there's a clinician somewhere in the loop of care, but the way AI can be leveraged to expand a clinician's capacity to see more patients helps scalability. So we have to be able to leverage the technology to provide the clinician's capacity to see as many patients as possible. And in a large way, the pandemic has made it something that is expected, appreciated, and actually normal.
Right.
Yeah.
And so like, I ask this, and that my dissertation, my focus in diabetes was all about digital connection with patients. And out of that work, the qualitative work that we did along that trial, what came out with patients was that technology connection to their coach or their clinician strengthened therapeutic alliance.
Right.
And improved adherence and accountability, because it wasn't just going to see your clinician in a bricks and mortar place, leaving, going back into your life, and then not seeing that clinician for maybe 2 months, 3 months, et cetera, and then coming back to report. But that you're actually still connected.
Right.
And it made a huge difference in their lives. And so I'm hearing that exact same thing from you.
Yeah, therapeutic alliance, it's a very important term. And I'm not sure people have therapeutic alliance to an AI bot.
Right.
I think that's a gap in the way that, an AI purely driven service, I don't know if it is able to entirely overcome. I could be wrong. And maybe it just becomes so ubiquitous and becomes your pal and someone you rely on to the extent where it really replaces a human. I'm not there in believing that the robots are taking over my most meaningful relationships. But I do think that it really can play a role in strengthening the therapeutic alliance by making responses more timely, by integrating all the data that someone has brought into a relationship and giving the clinician an opportunity to utilize it all in a very tailored response that doesn't require them to review the chart again.
Right.
So I think we get caught up in it being all or nothing, all AI
Right.
or all in person. But there are a million shades of gray that a given patient may align to better than the purely black or purely white approach. And so we're just trying to meet the patient where they're at. And the interesting part about PrehabRx, I mean, one of the many interesting parts, was that it was probably only a few weeks into our patient care delivery that we realized that some patients will never pick up the app.
Right.
And they will never get on virtual care, but they will talk to you. And they want you to pick up a phone, and they want you to have a conversation with them, and they want to do everything entirely over the phone. And so if that's where they are, then that's where we go. We meet them where they're at, and the phone allows us to scale for those who aren't comfortable with screen-based technology.
Right. And so, when we're starting to talk about this, and we're starting to talk about an overlap in the healthcare system, and one of the struggles in our healthcare system, a universal healthcare system, which we have every right to be proud of, but all appreciate that there are challenges. And one of the big issues right now, in Ontario at least, is access to primary care. And that's a big push by the government right now. One of the things that's a theme in this conversation that's happening right now is access to evidence-based programs like yours in communities that may not have the facilities and the infrastructure and the programming there. So making that available to Sioux Lookout, for example, or other places in Northern Ontario, or on Victoria, or in Vancouver Island.
Right.
So what's fascinating now is this conversation where you have a solution to supplement access in our universal healthcare system to evidence-based programs. But in some communities, in some areas, it's not necessarily embedded and under the umbrella of the Ministry of Health, of the traditional medical system. It's just connected, just outside of it, just connected to it.
Right.
Still relies on physicians to refer and medical centers to provide access.
Right.
But then this brings up this next question. So now it opens up, while it improves access, there's still barriers.
Right.
And some of those barriers are actually clinicians in feeling comfortable in referring to those. So what has your experience been, and we'll say this in the most politically sensitive way that we can, but what has been that experience? Because this is also something that is of consideration.
Yeah, there's no question that clinicians are a part of the long list of barriers. It's not intentional. Clinicians, whether they're physicians, nurses, or otherwise, have a whole sequence of things they have to do with a patient to improve their health. And sometimes the conversation around exercise just can't get squeezed into a very small number of minutes that they have with a given patient. And it's not because they don't want more minutes with that given patient. They have a waiting room of 60 patients outside that they also have to get to. So if they have to extend the conversation and add these other elements into their care for a given person, they are doing that at the expense of the next person in line, and so on and so forth. Time allowed per visit is a challenge, and they have to prioritize. And that's really it. It's really just a pragmatic issue. They could have the strongest exercise advocate. I have met really strong exercise advocates who simply just can't get to it. And that's a pragmatic barrier that really isn't a clinician barrier, it's a system-related barrier. And there are other ways that we're going to have to figure out to try to get the message to the patient that exercise is good for you, and you should see this professional over here. Some clinicians are just uncomfortable having the conversation because they don't know enough about it to answer a question. They hear it's good, but if they open up the conversation and they start getting questions, then they're put in a position that's a little bit uncomfortable for them. So I've heard that as well. I've heard also, I don't know where to send the patient. So for me to open up the conversation about exercise but not have a resource to send them to, really is unfair to the patient, because now you put them in a position of wanting a particular area of care for which we cannot support them adequately. So I wouldn't necessarily say that the clinician is a barrier because they're not advocates for it, but rather they don't necessarily always have the resources available or the time allocated to be able to have a conversation, even if the conversation only would take a minute. I'll also say that my response to this now is different than it may have been when I started this particular space 20 years ago, where some clinicians just had no idea that exercise could accommodate X, Y, Z challenge in care or symptom or whatever it may be. So I would say now clinicians are generally aware that exercise is good for people with cancer and other chronic conditions, that it can be done during the course of cancer care, and that challenges to actually driving that behavior are often pragmatic. And so solving for those pragmatic issues has been a focus.
Okay. And along those lines also, what is your response to the balance between like the public-private experience? Like, do you feel that there's a barrier because it's for lack of a better word, like a private enterprise providing service, like or not? And how do you talk through that?
It depends on the public-private debate is a contentious one. And one where a lot of emotions and feelings can be unearthed because of who we feel we are as Canadians, what is important to us, and universal healthcare is something that we really believe is a part of our culture. And I feel that way. I think that when developing a commercial enterprise like PrehabRx, at the core of our mission was to make sure that this was free for patients. So we've never felt that this is a private system separate from the public healthcare system, because we're not charging the patients for care. Our goal is to find ways to describe value for other stakeholders to make it worthwhile financially to invest in a patient's health. And if they can see the value of investing in a patient's health and make it free for the patient, then it really doesn't create two tiers, at least in my mind. Maybe there are some arguments for it in a different way. But, any patient can access this. It's not really about, having the resources to be able to access it, which typically is the big debate when it comes to public versus private. Okay, well, now only rich people are going to be able to get this care. Right. Now only those who are connected are going to be able to get this care. Again, you're providing care to the elite that everyone. Right. That's not what we're trying to do with this particular enterprise. And I think what we hope to achieve with PrehabRx is that we can demonstrate to other players there is value in creating a healthier patient that makes your business better. If you can invest a little bit into helping your patients get better, you will be able to drive a revenue stream that you weren't able to drive previously, or just open up new opportunities for business growth. Right. And maybe that will bring other players to the field. Maybe PrehabRx isn't the answer to all the things we're trying to do, but I think what we're trying to do is push others to think a little bit differently about how to create care, how to drive value, and make sure that people who need it get it for free without charging them, and creating this dualistic approach in the private and the public that can be problematic.
Right. And so, as you who have gone through this career trajectory, as you envision the future of what the possibility could look like, what would the ideal in this space, in this exercise, oncology, prehab space, what would the ideal look like from a patient care point of view, from a system level?
Well, I would love for patients to expect it. I would love for patients to, when they hear the terrifying words, "You have cancer," understand that there is more to their cancer care than attacking the tumor. Their cancer care includes supports to ensure that beyond the tumor, they are healthy. They'll be supported, and people who know a lot about cancer and exercise and other areas of health and well-being will be a part of their journey to ensure that a cancer and its treatment are a part of the experience, but they're not the entirety of the experience. And as much difficulty as it is to go through cancer treatment, their health will be invested in by a whole host of other health professionals. And we are hoping and trying to keep them as healthy as they possibly can be throughout the course of their care.
And what can, I guess, patients, clinicians, government officials, like what can be done? What are you hoping for from a support point of view to help see this vision come true? What are the things happening around you that you think would be beneficial?
What do I need?
What do you need?
I need people to talk about exercise and cancer more. And I need them to tell them that there are services available. I need them to look for those services, to drive demand for those services so that more people are asking for them, to create a space where others like us at PrehabRx are trying to fill that void. And I think if more people are talking about it, more people will find value. And that would mean we will have moved the needle a bit. And everyone on our side of the table, we'd be quite proud of that.
Okay, I'm going to break the fourth wall. You hear that? Okay. All right, last question before we wrap up. But like, is there anything that we didn't get a chance to talk about right now that you would like to talk about in this space that I have not primed you to speak to? Last chance.
Last chance. Oh gosh, where could I go with this? For patients and clinicians who manage and deal with cancer, there are a number of supports. And for my fellow researchers out there and others in this particular space, new ways of doing something are okay to try. We've learned a ton in the commercialization space. I have no idea if this is going to succeed, although I really hope it does. Because if it succeeds the way we hope it does, the outcome is more people with cancer will be able to have access to exercise resources. And that will have been a win. And so I think we've covered most of those points, but maybe just driving them home one last time.
Sounds good. Well, thank you so much, man. This has been an awesome conversation.
Yeah, Noah, it's been fun.
Very cool. Our first
we did
conversation, but we did it.
We did it. Congratulations to you.
Well, thank you very much
for getting this podcast launched, having great conversations with, I'm sure, a number of other people doing amazing things, and again, establishing yourself as a leader in this world. I've enjoyed watching your career, and I'm sure we'll do it for another 20 years.
Sounds
at least,
good.
Right?
Well, and then take a break.
And then we'll take a little break.
We'll take a little break.
Excellent.
Thank you so much, man.
No problem.
Appreciate it.
Excellent.